My name is Kate Goodrich, and I am the Director of the Center for Clinical Standards and Quality at CMS. The Quality Payment Program is the result of legislation that was passed by Congress in a bipartisan fashion in April of 2015. And the idea was to really incentivize the transition of payments to clinicians that are based currently mostly on volume to payments based upon value, really resulting in better health outcomes for patients. The Quality Payment Program combines and streamlines three existing quality programs, the PQRS, the Value Modifier, and the EHR Incentive Program, also known as the Meaningful Use Program, into a single construct where clinicians can either participate in a new program that streamlines those three called the Merit-Based Incentive Payment System, or they can participate in what's called an Advanced Alternative Payment Model and receive extra incentives if they are participating in those types of models. CMS has been working with many stakeholders from the clinician community, the patient community, other payers, purchasers, others within the federal government and state governments to develop the Quality Payment Program over the last year. The work of the Learning in Action Network, which began, over a year ago, I think, has significantly informed particularly the development of advanced alternative payment models. Beginning in year 3 of the Quality Payment Program, clinicians will be able to get credit for participating in advanced alternative payment models that go beyond just the Medicare program, that are run by commercial payers, and be able to get credit for that in the form of financial incentives. So the Learning in Action Network brings together commercial payers across the country. CMS is an active participant in the Learning in Action Network to define best practices around the development and implementation of alternative payment models, including topics such as population health measures that are most relevant and most useful for alternative payment models, financial incentive structures, attribution of measures to clinicians, and so forth. So by having the commercial payer world connect with the federal payment world, so with CMS and also with states, this allows for all stakeholders to really be able to align on the incentives and the measures and the implementation of alternative payment models, which will only benefit clinicians and then ultimately their patients who participate through these models as well. The QIN-QIOs in the recent past have been working with the clinician community on the Physician Value Modifier, which is one of the programs that the QPP is actually replacing. Recently, CMS awarded modifications to the QIN-QIO contracts to work with clinicians on the Quality Payment Program. CMS has other technical assistance work that is going on through the Transforming Clinical Practice Initiative and the technical assistance to the rural and underserved communities of practice to also align with the QPP and help clinicians to be successful not only in the MIPS program, but also to help them to transition into alternative payment model structures. So we believe that the QIN-QIOs play a very critical and significant role in educating and providing frontline assistance to clinicians to help them be successful under these new payment constructs. QPP has person-centered care at its very foundation and very core. In fact, that is called out within the legislation that authorized the Quality Payment Program. Through a number of activities related to quality measures, through improvement activities, as well as through use of health information technology through the Advancing Care Information category of MIPS. There are many measures and activities within those three categories that are very focused on helping clinicians to provide more person-centered care. Throughout all of the work that CMS, but most importantly that frontline clinicians are doing, we're trying to take a much more person-centered approach to the implementation of this program. And it's important to remember that these alternative payment models incentivize high-value care, incentivize care coordination, and incentivize patient engagement and shared decision-making. So we believe that the Quality Payment Program has been and will continue to be a very important stimulus to continue our transition to a majority of payments coming from Medicare and hopefully also from commercial payers to be through alternative payment models.